everyone, my name is Med2Med. This video is going to be all about potassium. This is such an important topic because if it's left untreated, the consequences of both hyper and hypokalemia can be catastrophic. These notes are based on the following resources. I've been using Scott's Notes recently. It's a PDF with concise notes of everything you need to know for medicine on the wards. As always, I've been using the Oxford Handbook of Clinical Medicine and utilising the NICE guidelines. As a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. Okay, so before I delve deep into the symptoms, recognising and treating hyper and hypokalemia, let's just go back to what we already know about potassium. It's a very important electrolyte involved in action potentials within a cell. For those of you who don't remember what an action potential is, it's the way a neuron transfers information down the axon, essentially an electrical impulse. Efflux of potassium, which is the outflow of potassium ions from a cell, decreases the membrane potential and hyperpolarizes the cell, i.e. makes it more negative. This is because potassium is a positively charged ion. So when it leaves the cell, it takes the positive charge with it and makes the cell negatively charged. This raises the threshold needed for the cell to be activated again. You can see this on step 3, where the cell is being repolarized, and in step 4, where the cell is hyperpolarized and below the threshold for another action potential to be generated. So depending on who you speak to, you will get different ranges for the normal potassium. But essentially, the normal range for potassium is around 3.5 to 5.3 millimoles per litre. This particular reference range is from Lab Tests Online UK. Regardless of what you consider to be the normal range of potassium, most people agree that a potassium of greater than 6.5 millimoles per litre or lower than 2.5 millimoles per litre is a medical emergency. So how would you recognise the symptoms of hyperkalemia? I like to think about this as the heart being in overdrive. Of course, some of these symptoms are the same with hypokalemia, but I want to highlight the fast, irregular pulse and chest pain. The other symptoms include weakness, palpitations, and lightheadedness caused by arrhythmias. So again, for hypokalemia, we have this triad of symptoms: the muscle weakness, the palpitations, and the lightheadedness. But we also have these different symptoms, such as hypotonia, which is poor muscle tone, decreased reflexes, cramps, tetany, and constipation. So let's think back to the action potential in order to understand how these symptoms come about. There is already very little potassium to begin with outside of the cell. So if you reduce that even more, the concentration gradient is even steeper, so the potassium is more likely to move out of the cell. This means that the cell is even more hyperpolarized than hyperkalemia, and it would take an even greater stimulus to reach the threshold for another action potential to be generated. Okay, we've covered the symptoms of both. Let's go back to hyperkalemia. So you've checked your patient's potassium levels and they're extremely high, but the patient is asymptomatic. What could that mean? Well, it's possible that their potassium levels aren't raised at all, and this is actually artifactual. There's a few reasons why this may happen. So firstly, by hemolysis, which can occur if the blood taking was particularly difficult, or if the patient had a clenched fist, it can raise these potassium levels. Next, contamination of the sample. So these 4 blood count bottles, which are the ones with the purple lid, have an EDTA anticoagulant in them. So if you start off with using the purple bottles first, it may contaminate the rest of the blood samples. For this reason, you should always do the usernese first. It could also be due to thrombocythemia, a disease where there are too many platelets. Potassium actually leaks out of platelets during clotting, so it could be raised due to this. Lastly, if analysis takes a particularly long time, potassium may leak out of the red blood cells. Otherwise, if you're certain that the result wasn't artifactual, then you need to address the cause of the hyperkalemia. Firstly, there's oliguric renal failure, so no urine produced or very little urine produced. It is the kidney's job to balance how much potassium is lost via the urine. If they are not working correctly, too much potassium will be retained. Potassium-sparing diuretics are really great at preventing too much potassium being lost into the urine, whilst at the same time increasing fluid loss from the body. So these are really good in heart failure because they prevent hypokalaemia. Of course, the reverse can occur, and it may result in hyperkalaemia. Next, rhabdomyolysis is associated with hyperkalaemia because it may induce kidney failure. So it's similar to the first reason. Potassium is exchanged for hydrogen within the body, which of course is an acid ion. So if the body is in metabolic acidosis, hyperkalemia can also occur. Obviously, if you're treating hypokalemia, then you may also induce the reverse. Addison's disease, which is adrenal insufficiency, results in hyperkalemia because of the low levels of aldosterone released by the adrenal glands. This leads to an increased sodium excretion and potassium retention, and by extension increases the potassium levels in the blood. Just remember that the renin-angiotensin-aldosterone system is what our body uses to control blood pressure. You can see in healthy individuals, this system stimulates aldosterone secretion and thus potassium secretion. But if this part of the system isn't working correctly, potassium will be retained. Then, massive blood transfusion can also cause hyperkalemia because red blood cells are filled with potassium. In response to burns, the body releases potassium, so in severe cases the patient may become hyperkalemic. And lastly, certain drugs such as ACE inhibitors cause hyperkalemia because again they affect this RAAS system as well as the nephron function. So we know we can recognise hyperkalemia on blood tests, VBGs and ABGs, but also on an ECG. Some of the things you may notice are tall tented T waves. You can see this in V4 of the ECG on the screen. The T waves are abnormally large and tented in shape. In moderate hyperkalemia, so that's around 6.5 to 7.5 millimoles, you may get flattened P wave, which you can see on V5. You might also get a prolonged QRS complex. In severe cases, this QRS complex just keeps getting wider and you might also see some axis deviation or bundle branch blocks. In some cases, it may lead to ventricular fibrillation. So, in order to treat non-emergency hyperkalemia, you would give polystyrene sulfonate resin. This binds to the potassium in the gut and prevents absorption and brings the potassium levels down over several days, i.e. this works by a gastro route, so it's less intense, it's not a medical emergency. If the patient is vomiting, you can give a 30-gram enema followed by colonic irrigation after 9 hours. So that's in a non-emergency, but if the potassium is greater than 6.5 millimoles per litre, as we mentioned, or there are changes on an ECG, then you need to give 10 millilitres of 10% calcium chloride. Now this doesn't directly treat the hyperkalemia, it's cardioprotective, so it's really good at protecting the heart. Next, you give 10 units of intravenous insulin in 25 grams of glucose. This is because it stimulates the intracellular uptake of potassium, which in turn lowers the serum potassium. So this is directly treating the hyperkalemia. And of course, there's the glucose added in there, so you don't induce hypoglycemia. Then you can actually give salbutamol, so that's 10 to 20 milligrams in a nebulizer because it's quite a high quantity. And again, this also causes an intracellular potassium shift. Lastly, in really severe cases where you cannot correct the underlying pathology, you may need to give renal replacement therapy. I've actually gone over this treatment regime in a previous lecture on acute kidney injuries, so it might be worth taking a look at. Okay, so we've learnt about the symptoms of hyperkalemia. We've looked at how to recognise it on tests, on ECGs, and we've also talked about how to treat it in a non-emergency setting and in an emergency setting. So let's look at hypokalemia. So again, You can recognise it on all of your generic tests, but specifically on ECG, you may see some hyperkalemic changes. It's pretty much the inverse of hyperkalemia, which is great because then it's an easy way to remember it. So you might notice some small or even inverted T waves. So remember, in hyperkalemia they're tall and tented, but here they're small or even inverted. You can get the development of something called a U wave, so that's seen after the T wave and before the P wave. So these are thought to be due to the repolarization of the Purkinje fibers, and they can also occur in hypothermia. You may also notice a long PR interval and depressed ST segments. So just like how the ECG works, the causes of hypokalemia link really nicely with those of hyperkalemia. They make logical sense, so it shouldn't be too hard to learn or at least understand for now. So loop and thiazide diuretics increase sodium delivery to the distal segment of the distal tubule. This increases potassium loss into the urine. So as we've spoken about, we understand that potassium sparing diuretics will increase potassium, which is why they're good in heart failure. However, with loop and thiazide diuretics, these do the opposite. An increase in bicarbonate ions is a telltale sign that hyperkalemia has been long-standing in diuretic use. Diarrhea and vomiting also causes dehydration and hypovolemia, which in turn activates this RAAS system in order to increase the blood pressure. This means that aldosterone is secreted and potassium is lost into the urine, hence hypokalemia. Again, pyloric stenosis induces this hypovolemia, as well as a metabolic alkalosis, which causes a loss of hydrogen ions. Rectal villus adenomas also cause hypovolemia and watery diarrhea as well. Internal fistulas cause hypokalemia due to the loss of this fluid rich in ions such as potassium. Cushing's, steroids and ACTH work in the opposite way to Addison's, so of course again increase in aldosterone, which is part of this system. So this causes potassium excretion via the urine. Again, cons works pretty much in exactly the same way by hyperaldosteronism. You may suspect potentially a cons patient if the patient is particularly hypertensive, hyperkalemic and alkalotic, particularly in someone who isn't taking diuretics. Alkalosis shifts the potassium out of the plasma and interstitial fluids into the urine in exchange for hydrogen ions. So again, hypokalemia, we know that acidosis causes hyperkalemia. In this case, we know alkalosis causes hypokalemia. Purging and licorice can also cause hyperkalemia as well as this volume depletion. Lastly, renal tubular failure causes hypokalemia through a few hypothesized methods. So either increased leakage of potassium into the lumen, less reabsorption, and aldosterone stimulation. So in mild cases of hyperkalemia, which is 2.5 greater than, so that otherwise that's the emergency cutoff point, you can give oral potassium, which you will then review after 3 days. And of course, if this is induced by loop or thiazide diuretics, you would consider giving them a potassium-sparing one instead. So in an emergency, you need to be more cautious. Although we recognise for hyperkalemia we really want to immediately bring this down, you don't want to immediately overload the patient with potassium. So you're going to give no more than 20 millimole per hour and no more concentrated than 40 millimole per litre. You need to bring it up slowly so you're not accidentally causing hyperkalemia. But note, if the patient is oliguric, you cannot give potassium. Brilliant, we've finished. So here's the summary. The normal ranges of potassium are about 3.5 to 5.3 millimoles per litre. Hyperkalemia specifically presents with a fast heart rate and chest pain. Hypokalemia specific symptoms are hypotonia, hyporeflexia, tetany, cramps and constipation. Both of these conditions present with palpitations, lightheadedness and muscle weakness. If your patient has no symptoms but is very hyperkalemic, it could be artifactal, so you need to repeat the test urgently. ECGs for hyperkalemia may show tall tented T waves, small P waves, a wide QRS, and potentially VF. ECGs in hypokalemia may have small or even inverted T waves, prominent U waves, a long PR interval, and depressed ST segments. Mild hyperkalemia should be treated with polystyrene sulfate resin, but severe should be treated with calcium chloride for cardioprotection, insulin, and salbutamol. Mild hyperkalemia should be treated with supplements, as we know, and potentially a change in diuretics if this is the leading issue. If you're treating severe hypokalemia, you give IV potassium cautiously. You don't want to cause hyperkalemia. And that's it. Thank you for watching.